Hello, everyone, and welcome to Johnny's Ambassadors. I'm Laura Stack, the founder and CEO of Johnny's Ambassadors, where we educate parents and teens on the dangers of today's high potency THC in marijuana on adolescent brain development and psychosis and suicide. We have another excellent guest with us here today, Jay Voigt, whom I will introduce in just a moment. After I go over a couple of quick logistics, this session is being recorded so that you can share it with your friends and family. Jay has kindly provided a handout of his slides, which you can find in your control panel under the section that says handouts. Just click on that PDF and you can print it or refer to it as you go, or it is on the page where you are watching this recording. Jay will be speaking for about 45 minutes with slides, and at the end, he is going to take some questions. So in your control panel, there is a question box. If you would please type in questions or answers as we go, and he will take those in the last 45 minutes of our session. So without any further ado, I'd like to introduce Jay Voigt, who is a seasoned behavioral health clinician and dedicated leader with nearly 20 years experience working in complex systems and serving vulnerable populations. His clinical interests include family systems, trauma, attachment, and co-occurring disorders. Jay has experience working in various systems, including schools, homes, jails, hospitals, and outpatient settings. Jay is the executive director of Mount St. Vincent, a treatment center serving children and families impacted by substance use and trauma. Jay completed his MBA in healthcare administration from the University of Colorado, Denver, and he earned a master's degree in counseling education from Pennsylvania State University. He is a licensed professional counselor and a certified addictions counselor. He has experience serving on multiple nonprofit boards and advocating for policy change before the Colorado State Legislature. Jay lives in Westminster, Colorado with his wife, Marcy. He enjoys the outdoors and spending time with family. Jay, thank you for being here and for being one of Johnny's ambassadors.
Thank you so much, Laura. Pleasure to be here. Good morning, everybody. Hope everyone's doing well. I have about 30 slides that we'll go through, and we can go ahead and get started. Thanks for the kind introduction, and it's an honor to be a Johnny's ambassador. So briefly about me, been doing behavioral health for about 18 years. Lots of different settings, like Laura had described. I'm a clinician at heart, and I got into administrative work probably about 10 years ago, and now I'm the executive director of Mount St. Vincent Home, which is a complete treatment care continuum for traumatized children ages 5 through 12. I also have lived experience. I'm active on several nonprofits boards currently and in the past. And then as far as the legislative process goes, I've spent some time down at the Capitol supporting some bills. And then the last reason you should listen to me today is I'm going to be honest with you. So I do want to just point out this picture right here. There's a picture of me getting my COVID shot. So this is a gentle nudge to everybody. If you haven't made up your mind as to whether or not you're going to get the vaccine, you absolutely should. Learning objectives for today. So we're going to talk about entry points into the behavioral health continuum. So through the traditional healthcare setting, maybe like your primary care office, or through maybe a specialty clinic, maybe like a psychiatrist's office. We're also going to talk about, what is this continuum of care, and what does that mean? What does it look like? And what does a continuum of care have to do with treating chronic illnesses? So specifically, we're talking about cannabis use disorder, cannabis-induced psychosis. There's many other things that are co-occurring with cannabis use that we'll cover today. And then finally, we're going to talk a little bit about elements of a productive therapeutic relationship. This picture over here on the right, this is a picture of Mount St. Vincent. When we have children graduating from our programs, we form what we call the tunnel of love, and this is one of our children and one of our therapy dogs going through the tunnel of love. So before we get into the meat, I just want to throw out there goals of parenting. Whenever I'm presenting on a topic, I like to Google it and see what kind of nonsense the internet puts up. Sometimes it gives me some good stuff. Sometimes it gives me some fluff. But as you can read through these definitions, the professionals at Psych Central, there's their definition. Lifehack.org, right? There's a reputable source of information. I'm being sarcastic for those of you that don't know me. But okay, they think that that's the goal. Thoughtful Parent says to foster resilience. The best clinician I know is Dr. Michael Barnes. And when I told him I was presenting, I asked him what he thought the goal of parenting was. And this is a guy who's got a PhD and has done tons of family therapy, knows more about trauma than anyone I've ever met. And he had made the comment, just get up to 25 with minimal pregnancies, loss of limbs, and criminal charges. It was kind of tongue in cheek, but he was kind of serious. I think for a lot of parents, especially with their firstborn, their goal of parenting is to raise a Harvard graduated lawyer. And that's not always realistic. So now let's take the kid perspective. So for a child, what's the goal of being a kid? Getting through high school, getting out of the house, finding someone to love me, having fun. If I were to ask my 11-year-old nephews what their goal is, it's to get more screen time. Then if we ask the developmental experts, they would tell us the goal is to individuate from parents. And adolescents need to develop identity and intimate relationships and develop coping skills. The point of this slide and the previous slide is we're coming from different places. We don't all necessarily have the same goal or desire in mind. So I'd like to do a real quick audience poll. Laura, you want to go ahead and run the poll?
Absolutely. All right, let me put the poll up here. The first one is, why did you attend today? My reason for attending this webinar is, if you would click on one of these options to help a family member, to help a friend, to help myself, or if it's other, type your answer into the question box so I can read that out. This will be very helpful for Jay as he is presenting the rest of the material to us. Okay, about half of you have voted. The other half are doing email. Come back to us. Click on one of these options and let's see what we have here, Jay. Some are typing other. If you want to type a response into the question box, if you've typed other, that will help us get an idea. All right, let's close that poll, Jay, and I will share these results with you. Can you see those answers?
I cannot.
Okay, so I'll read these out to you. 43% say to help a family member, 14% to help a friend, 14% to help myself, and other 29%. I yet don't have any responses yet for the other there, Jay. Do you want me to put up the second slide?
I think we're the second poll.
The second poll, I
Yes,
mean.
please do.
All right, so which of these three learning objectives are you interested in the most? And in this one, you can select all that apply. Behavioral health entry points, continuums of care, productive therapeutic relationship, or to verify that Jay does in fact bear a striking resemblance, and that should say to Chuck Norris. Oh yeah, that's the one I would pick. Okay, so click on any of these that you are interested in the most so that we can share these results with Jay to guide his presentation. All right, I see votes coming in. And if you want to click anything else in the question box. Okay, so Jay, we have one answer in the question box to help my community. That was from the previous one.
Okay.
Reason for attending. Okay, so let's close this poll here and share the responses. Jay, 63% said behavioral health entry points, followed by the next highest, 38% productive therapeutic relationship, and 25% continuums of care. Oh, and look, 13% just want to verify that you do indeed look like Chuck Norris.
Thank you, Laura.
All
Thank you
right.
so much.
I put your slides back up here, Jay.
Okay. So thanks, everybody. It gives me a sense of where you're coming from. And I mean, I think the overall sentiment is this is really personal to many of us. And there's a hope or expectation that each of you walks away today with some real knowledge or understanding or information that you can use to help someone in your life. So I will do my best to deliver that. Before we move to the next slide, this is my dog Remington, and this is my niece Kylie. And Remington did not have a good day on Christmas, but Kylie loved it. So let's talk a little bit about why it is that people seek care. Other efforts have failed. So in residential treatment settings, typically people have had many experiences at lower levels of care, and sometimes in other residential settings. With addiction treatment, increased consequences, I think, are the #1 reason we see folks for the most part. It's pretty rare that someone just shows up on the doorstep of an addiction treatment center and says, I woke up today and I just really want to change my life. Typically, there's a divorce, a legal charge, something like that. That's not necessarily a bad thing. Worsening of symptoms. So typically that's when it's interfering with life responsibilities. So for example, with psychosis, if I didn't have psychosis and I do now, that might be a reason I would seek treatment, or my psychosis is worsening. Unexplainable change. Typically, when there's a question mark and there's some pretty severe consequences, folks might turn to a medical professional or a mental health professional to try to account for some of those unexplainable changes. Previous previous unsuccessful treatment efforts. Okay, we're getting a little redundant here. The last one, which is important, and we're going to come back and talk about this in a couple different contexts, is folks might not like the recommendations they got from a previous provider. So the doctor tells me that I should stop smoking pot. It's affecting my health. I go doctor shopping and find someone else that prescribes it for me, right? So how do people seek treatment? So right now I'm just talking about Americans in general. I remember the phone book. I remember picking a professional based on who was closest to me. But right now, current day, we're seeing a lot of people use the internet to help them decide, make a decision as to what would be the best provider for them. Other folks were still professional referrals. That's pretty common. And then personal referrals. So if I wanted a counselor, for example, am I more likely to ask my friend, or am I more likely to get a referral from a professional? Who knows? But I think that kind of depends on the person. When we're talking about mental health and substance use disorder, there's a lot of stigma involved. So this isn't necessarily a safe topic for many of us in our own personal relationships. So web definitely is how people are primarily seeking out treatment. So right now, according to this poll, 69% of consumers are really looking at positive patient reviews. 60.8% of consumers are avoiding doctors based on negative reviews. One thing, about 2 years ago, there was a survey out there that identified Yelp is the #1 source that folks were using to promote their or to receive medical care. And that was pretty shocking to me when I saw that. I mean, I thought about that kind of like, where do I want to go for pizza? Where do I want to go to get medical care, right? They're two very different things, but the world has changed. So we need to keep all this in mind as we're talking about seeking behavioral health treatment. So who seeks treatment? So remember I made that comment a little bit earlier about it's rare someone shows up on the doorstep of an addiction treatment center saying, I wish I just woke up and wanted to change my life today. Typically, folks are pushed or encouraged into treatment in one form or another. And so this statistic here is very general. So in general, in America, women and the head of the household, women are making the predominant decisions for family members. And then the little caveat here is oftentimes there's disproportionate coverage. So I'm not going to go into a political rant or anything, but the Affordable Care Act opened up and made it possible for a lot of folks that didn't traditionally have healthcare coverage to get healthcare coverage. So we've seen and we'll continue to see some changes in studies, being conducted longitudinally about healthcare access and healthcare usage behaviors. So let's jump into the continuum of care. So a bunch of you said, hey, I really want to talk about the continuum of care. What is it? So here we go. Continuum of care. Oops, sorry. So this is a graphic describing, or I guess illustrating kind of our traditional mental health system or behavioral health system. Essentially, the idea is we have all these different services that can be provided. Many of you are familiar with a lot of these. So for example, outpatient care, right? That means you're scheduling to go get therapy for an hour, or you're going to see a psychiatrist quarterly, something like that. So some more intensive options would be intensive outpatient. So typically intensive outpatient is 3 groups 3 times a week, 3 hours a pop, maybe some adjunct individual treatment. Partial hospitalization, this typically is more similar to a day treatment program. It's about 30 hours a week. This varies by state, varies by payer. Day treatment program, you could think of that more as a job, 40 hours a week, you go somewhere and get treatment. Mobile crisis comes to you. We all know what an emergency room is. Colorado, we've opened up some crisis services that you can stop in. I think there's like 5 throughout the state. Inpatient psychiatric hospital. For most people, when they think about mental health treatment, they think about outpatient care, and then they think about inpatient psychiatric stuff. Therapeutic group homes, community residents, residential treatment facility. So you have the slides, you can go back. I don't want to get in and tear all these apart, but the point of this slide is there's lots of different things you can do. And I'm guessing you're probably not familiar with all of these, and you're more likely familiar with a couple of these, and that's problematic for a couple reasons. Let me shift gears, and now we'll go to the next slide, and let's look at our addiction treatment continuum. So our addiction treatment continuum here is least restrictive to most restrictive. Early intervention, like education, remember the DARE program. Outpatient services, once a week, once a month. Intensive outpatient, we went through that. And then this whole cadre of services right here basically is just ramping up. So when most people think of rehab, they're really probably talking about this, clinically managed low intensive residential services. When you shift to some of these, there's increased medical needs, and there's more intensive services associated with that. So if we think about behavioral health care, when I say behavioral health, I'm talking about mental health and physical health, or I'm sorry, mental health and substance use disorder. Traditionally, we've separated the two, and now we're lumping them together for a lot of reasons. But the idea is you start at the lowest level and work your way up. So I got my first DUI. I might not be an alcoholic. I'm a problem drinker. Chances are I'm not going to start off in rehab. Maybe I'll do, some outpatient counseling. So here's a bunch of different services. So the thought is that start low, work your way up as needed. And if you remember at the beginning of this presentation, I talked about the parents have one goal, kids have another goal, professionals have another. Here's the reality. It's tough when you're doing a webinar and you can't see or hear the audience. I hope there's some laugh in there. The point of this slide is people are complex, people are unique. We don't fit into boxes, and we have to find a balance between what we should do, what we can do, and what we want to do. And most people don't access services in a linear fashion like we have going on here. And that's okay. So, a little bit about our continuum. So now we're talking about kids, we're talking about adolescents. So let's look a little bit about how they're using care. So this is an older 2014, but essentially, 24 million adolescents in 2014, and they were receiving care in specialty settings, about 3 mil in educational settings, and then 700,000 in general medical. So this is general medical settings, this slide right here. So when people are going to their primary care doctor, usually that's what we're talking about with a general medical setting, this is what they're going to say they're coming in for. I'm coming in for feeling depressed. I'm coming in for thoughts about killing myself. So, these are very depression related things. And as we look down, these are things that we might look more to maybe a psychotherapist to help us with. So when we ask teens, hey, what's the prevalence of some of these issues that you're dealing with? And this is 2018 data. Teens are going to say, the leading problem with their peers are anxiety and depression. It might not be a surprise to you. This might be a surprise to you. Oops, sorry. Bullying. Bullying is huge, and it looks a lot different than it was when I was growing up. Cyberbullying, frequency, intensity, duration, the ability to cascade messages out. This is having a real impact, and this is a webinar for a different time. But I just want to draw everyone's attention to this. Like, this is really important. Give you a sec to take this in before I go to the next one. So here's some CDC data looking at depression, anxiety, and behavior disorders. So this is kind of our wastebasket here. This is prevalence. So we're looking at this 2 to 17, we're talking, or 12 to 17, we're talking about adolescents. So according to this, 6% of adolescents in this age range suffer from depression. About a little over 10% are suffering from anxiety, and then they're saying about 7% are experiencing other behavior disorders. So that could include, psychosis, personality disorders, things like that. The takeaway from this slide is there's a real prevalence of diagnosable mental illness out there. And when we look back to our previous slide to teens' perceptions, their perceptions are kind of accurate with this. But they're perceiving drug addiction and poverty and pregnancy to be a much bigger problem than maybe we might see in other graphics or statistics, if you will. Promise, guys, there's just a couple more of these numbery slides, but I'm just trying to give you a sense of, statistics, not necessarily what we think and what we feel, because sometimes those don't match. So this was a 2010 study that looked at how this study was about Medicaid and private insurance. I'm not so concerned about that right now. What I'm most concerned about are treatments of adolescents and what it looked like in 2010. So in 2010, it looks like you had about a 50% chance to get psychotropic medications for your treatment, right? Take meds, don't need to bother with counseling. Back then, so there are disparities. So these are economic and social justice related disparities. I'm not trying to go there today, but it is notable. Psychotropics and meds, we know that the best case scenario when people are seeking care for a behavioral health disorder, when indicated, when medications are indicated, it's always best that we take medications with therapy. And here's a small percentage, don't want to take the pill, I just want to do therapy only. And this is nothing. Okay, so this is 2009. Fast forward to today. Oops. Sorry, I have a little trouble here. Okay, I just want to start off by saying that this is the National Academy of Sciences, in case anybody was interested. And this really should be 2 slides, but it's all in one slide right now. And what we're looking at are treatment modalities for the first 3 months of a typical course of treatment, so of American adolescents. So current day, If someone's seeking treatment for a behavioral health disorder, they're much more likely to seek therapy than they did before. Like way more likely. Before, I think it was 11%, 6%, we'll call it 8. So much, much greater. Drugs alone, that hasn't changed that much. Drugs and therapy, only about 6%, and then nothing about 30%. So if we know that best case scenario for most folks is this, why is that not happening? So let's talk about B for a minute. So try and tune this out. Looking at B, red flag treatments are basically treatments that are not indicated based upon someone's medical history or their presenting demographic. So for example, to give benzodiazepines to people with opiate use disorder, maybe or people on pain medications is deadly. And it took us a while to figure that out. So that's an example of a red flag indication. So if you're looking at this, it looks like almost half of our initial pharmacological treatments, so we're talking about drugs alone or drugs and therapy, so just this little 30%. So this 30% is this whole 100%. Almost half of them are taking some kind of psychotropic medication that could be problematic. Benzos in kids, oh, I can't believe we're even having this conversation. Non-FDA approved treatments, okay, that makes a little bit of sense. That's not that uncommon. Tricyclics, these are antidepressant medications, older meds that came out in the 50s, and they have a lot of side effects, so they're generally not your first tier that you're going to look at when you're doing a pharmacological intervention. And then this is undefined. So your takeaway from this particular slide is a medical professional told you your child should take X, Y, and Z. Well, there's a good chance you might want to have a conversation with a different professional or talk that through. All right, so now we're shifting gears. Just have 3 more slides in the science stuff, and then we'll get into some more softer, hopefully tangible stuff. But I want you to have a solid foundation. So this particular study that we're talking about from 2012, we're really looking at the efficacy of outpatient treatment for adolescent substance abuse. So what they did is they took 12-step therapy, family-based intervention. CBT stands for cognitive behavioral therapy, motivational interviewing, motivational therapy, and other approaches. And what they found was a consistent pattern emerged from all the therapies that they were pretty similar. But we did find that family therapy and motivational therapies are superior typically when we're dealing with kids. This family therapy component is huge. When we're dealing with adolescents, families are central. They're super, super important. So the same study, this meta-analysis means that they took a bunch of studies and they put them all together and they compared them side by side to see what they reflected. And the idea with a meta-analysis is if you're taking a whole bunch of data and you're trying to make it apples to apples, you'll get a better picture than maybe one study that might have a potential bias in it. So take away from this that we can generalize the most powerful treatment outcome in addiction, and oftentimes in general behavioral health or mental health, has to do with this therapeutic alliance. And we're going to talk about that last, but very noteworthy. And then bottom part here, talking about average range of sustained abstinence after treatment, 38% at 6 months. That gives you a kind of snapshot of what the analysis was looking at. When we're talking about substance use disorder, a lot of times the goal or assumed goal is complete abstinence. Never use a substance again. And unfortunately, that's usually not how it works. Relapse is fairly common. In fact, I would expect it rather than not when it comes to someone engaging in treatment, putting down the drug and being abstinent for the rest of their life. So we need to be mindful when we're talking about what success is. So consider this, especially those of you that have a friend or if you're a parent. If you met with a therapist and they said the goal was for your kid to smoke half as much pot, how would that go over with you? You need to think about that. You need to put that out there, have that conversation. I think most parents that are trying to seek care for their kid absolutely would love them not to ever use any substance ever again. But if that's likely to happen, what's plan B? What's the game plan? How is that going to be handled? And we'll talk about that more when we talk about different providers.
The final slide I have about this meta-analysis is talking about variables that are most likely to predict a successful treatment outcome. So treatment completion being number one. So half of Americans can't take a 30-day prescription of medication given to them by their physician for just regular medical stuff. We're not good at treatment completion. When it comes to substance use disorder, it's very common people want to drop out a treatment early. Low pre-treatment substance use, right? The less acute you are when you seek treatment, the better you are when it's not as complex, it's easier to treat. And then the last variable is patient, peer, and parent social support. So who you're spending time with, really, that's who you need to be interested in. I'm hanging out with people doing drugs and more likely to do drugs. So that's not really rocket science. Jumping down, the last thing I want to say is, before I'd said that all the treatments are pretty similar. The one exception to that is outpatient family therapy. And whatever the form of treatment is, having the family involved is critical to having a good outcome. So now, audience poll, Laura, would you mind taking over and sending the final poll out, please?
Yes, all right. The last poll is, what is the biggest challenge people have around accessing behavioral health care? So based on what Jay's discussed and your experience, is it cost, distance, provider-client match, motivation, or if you select other, please enter that response into the question box. Okay, so our poll is open. If you could click on the one that you most think is the problem, and if you type other, would love to hear your input into the question box. Okay, we have about 46% voted. Let's leave it open here for just another few seconds, and we'll see what we have. All right, Jay, we have 40% saying that it's the provider-client match, and then all the others are tied. Cost, motivation, and other are at 20%, and one person gives the feedback of hard to find providers who have availability, Jay.
Great. Thank you, Laura. Excellent. I got to tell you, audience, I'm surprised that I think you were correct about the match. I expected that would be a lesser of an issue, but I think you're absolutely right in this particular realm. So, I mean, kind of matching is very, very important. There's been research done on matching and how relevant that is. But right now we're talking about kids, right? Talking about adolescents. Adolescents are finicky by nature. Throw on top any kind of other, complications, they're going to be more and more finicky. That match is so important. So let's jump into kind of what that match looks like. As for cost and access and all those other things, absolutely correct as well. Really good clinicians are really busy. It's real hard to get onto their schedule. So let's talk about a therapeutic relationship. I put a picture up of Dr. Drew, and I like Dr. Drew. I think a lot can be learned from him and his demeanor, particularly the way he was 10 years ago. He's gotten a little more jaded lately. But if you watch some of Dr. Drew, I think he does a pretty good job of kind of exuding some of these qualities. So let me go back to this slide. So the thing about a therapeutic relationship, matching's so hard. How do you tell from somebody's website or a brief phone call with them if they're going to be a good match for your person? So this next slide, I'm going to talk a little bit about assessment. If we want to make it easier to do that match, let's rule out some variables that could make it difficult. So some of the best clinicians I know don't have PhDs. In fact, there's some studies that show the higher level of education you have, the less able you're effectively to engage with certain populations. So for this crowd right now, in the context of our conversation, I'm going to say, look for a licensed and certified clinician. Here's some credentials. Certified, I'm talking about being a certified addictions counselor. Having these credentials ensures a couple things. One, you spend some time learning some stuff. You're able to complete a program. You've signed a code of ethics that you're bound to and are more likely to adhere to than someone that had not. If you seek out these type of folks, you're much less likely to engage in poor therapeutic boundaries. In addiction treatment, what happens is you get a lot of folks that get clean and they want to become counselors and therapists and clinicians, and they don't seek out the training. And they're well intended, but without the training, oftentimes their goodwill, their empathy, their feelings, their emotions can cloud their judgment, and they're not making the best possible decisions. They could border on unethical or even illegal. So if you seek out a licensed and certified person, at least they're aware of what those things are, and there's some consequences if they violate that. So when you're seeking out care, we're running out of time, guys, so I'm gonna have to pick it up a little bit. When you're seeking care, get someone that's licensed, get somebody that has reviews, or someone tells you, displays these things. What's your interaction when you talk to this person or email with them? A good assessment, you're going to want to get collateral, you're going to want to get longitudinal data, and in all cases, for what we're talking about, substance use disorder, you always got to do tox screens. So UAs, right, urinalysis. There's an old joke, how do you know when an addict is lying? Their lips are moving. There can be some truth to that. There's some components of substance use treatment that make it really difficult for people to be honest about their using. So I'm going to insist, if this isn't part of your assessment, you're not getting a good assessment. As far as getting collateral, any clinician that sits with you or your loved one for an hour and a half and tells you they have it all figured out and this is what needs to happen, isn't doing it right. So there's a couple of reasons for that. One, they don't have the context. So they need more of the story. They don't have all the information. The other part of that is one of the biggest challenges I've had in the past with working with parents and kids is they didn't want to follow my recommendation. And that happens for a lot of reasons. One, we don't agree on what the problem is. I have not explained clearly in a way they could hear what the problem is. So my recommendation wouldn't make sense to them. Two, I came to the recommendation hastily. Three, I didn't have a therapeutic rapport with them and I wasn't able to make a recommendation in a way that they could hear. Four, I think I'm on four, the recommendation wasn't realistic. Remember how we looked at how people use healthcare and we saw a little Billy running around up and down? Good recommendations are tiered. If the answer is only one answer, you might want to get a second opinion somewhere. So when you're getting a clinical recommendation, a couple things to consider. You saw a previous slide with the different levels of care. First thing they should recommend is, what level of care is it? Is it group? Is it residential? Is it day treatment? Is it outpatient? What's the level of care that they're recommending? And what kind of provider is it? Are they recommending someone that specializes in addiction, someone that specializes in trauma, specializes in both, families? You should really be specific with that. And the recommendation has to consider likelihood of engagement. So oftentimes, I have made recommendations or seen other providers make recommendations that say, I want you to come here twice a week, and the person doesn't have a car, right? That's a rookie mistake. That doesn't make sense. Or you need to go to residential treatment. Does that mean quitting your job? That's a pretty big thing for a clinician to ask. That really needs to be talked through. Consistency is important. So if I'm getting a good tiered recommendation, I need something that I can consistently attend. So if the consistency is I need you to show up once a week and you can't do that, that might not be an accurate or relevant recommendation. And the last one is UA monitoring. I already mentioned that in the last slide, but this is so important for adolescents. So winding down, summarizing what we talked about today, I'd ask each of you on this call that's trying to help somebody else to do your own work. No one ever wants to hear this, but You know, the old adage about, you know, the oxygen mask, and you got to put it on yourself before you can put it on your child, you know, on an airplane. You got to do your own work. There isn't a whole lot of empathy typically given to families and people like you on the call that are trying to help someone. I'll have you know that people like me, addicts, I'm in recovery, are really good at making support systems crazy. And you guys, we've impacted you, and I'm sorry for that. Do your own work so you can best help yourself and help us. Formal treatment's important, but often overvalued. Answer rarely is going to be one psychiatrist or one therapist or one course of treatment. It's going to be diet and exercise and the bowling team and spirituality, whatever your deal is. You have to look beyond a lot of these things that I talked about today. Relationships are what foster change, and recovery is a journey. So this is a process. So I'll just close out with this C.S. Lewis quote: "Hardships often prepare ordinary people for extraordinary destinies." And I'll tell you, that is my experience. So many incredible people I know, that has been their deal. I'm talking about you, Laura. Thank you so much for giving me the opportunity to come and present today and be one of Johnny's ambassadors. And with that, I will turn it back over to Laura. Thank you.
Thank you, Jay. If you could stay on that last slide so that people can see where to contact you and how to get information with Mount St. Vincent or West Pines, which is for adults 18 and over with substance use disorder, and also family issues, and a phone number there for Ronnie DiCarlo. And Jay, we have some questions if you have some time yet remaining in our session.
Absolutely, and please don't hesitate to email me, everyone. My email was on the first slide.
Wonderful. Okay, so everyone type your questions. I will read the first one. It says, this webcast is about teens, and can you address how parents can best get help for kids who are over 21, since you can't force them to go, and many providers won't talk directly to parents. And Jay, it can even be for 18-year-olds who can withdraw their consent, you know, at that point for anybody to talk to them. So what do you do at 18 if you're a parent, at 21 if you're a parent and your child is experiencing mental health or behavioral issues?
You bet. I'll try to answer that concisely so we have time for a bunch of questions. Again, that's a whole nother webinar. Short answer is that is the expectation. A good treatment provider is going to know that that's the problem. Insiders working in residential addiction treatment, we call that the ROI game. It's very common that particularly teens and young adults would revoke a release of information because they don't like our recommendation. And it's yes, it's a symptom of resistance, and resistance comes and goes, so it's not abnormal. In terms of working through that, this comes back to you either working with that agency or working with someone else to help you best navigate that. Call Ronnie. I promise you Ronnie will be able to help you navigate that. There's no simple, easy answer. It takes work. It takes a lot of work. And for you to do that work and effectively navigate that situation, I'd say you need to be with a top tier addiction treatment provider that specializes in family and has family programs, or you need to be working with an individual to help you navigate the treatment at that particular facility. Great question.
Okay, and another comment that just came in related to that. So if a young adult, say 23 years old, wants to recover, there's little for a parent to do besides get the information and try to help, but take care of yourself in order to guide your child. I think there's a lot of crazy making that goes on with the parents as well, Jay.
Yeah, you bet. And sometimes I'll just throw this out there. I am so sorry for those of you that are having to deal with this. It's really hard, and we don't give the families enough credit. The focus is always on the illness, the sick, the using person. It's difficult to make people do things, but there's definitely ways to get folks to do stuff. So people use interventionists, but a lot of times for families, it has to do with setting boundaries. And if you want to know what those boundaries are and how to set them, again, it's a very complex topic. I'd say give Ronnie a call.
Maybe we can get him on another webinar. You can make that introduction for us, Jay.
Sure.
I'm not shy asking. And that's another question that came up. What are some support systems available for parents who they themselves need to access care and support, self-care resources? Are there groups? How do parents who come in to, who are having a child, say, with cannabis-induced psychosis, what kind of support systems and treatment are available for the parent?
Sure. I start off by saying whoever is, if the child's in treatment, contact that provider. You want to work with an organization or group or person that has a relationship with the provider that's treating the child. So whenever possible, you have this network, right? It takes a village. There's lots of free groups available online. Al-Anon is one particular one, Narcanon. There's a lot of faith-based groups that have services like that, throughout the country.
We also have Marnon, which is for families of the marijuana addict himself or herself, not the user, but the loved ones of that family member. And on our website at johnnysambassadors.org/parents, we have the login information for 2 Maranon groups hosted by Bart Bright, Jay, every Monday and Tuesday. So that's yet another support mechanism available for parents and loved ones.
Thank you. Yes, absolutely.
Great. Let's see. Well, what if the insurance does not pay for treatment? Many insurance providers feel that marijuana is, quote, just weed and will not cover that treatment.
Yep, very common, not a new issue. The initial thing I say, if you're here in the Denver metro area, first place I would call is Sparrow Recovery. So they are a reduced Sparrow Recovery. I can email the info if someone needs it. They're located in Evergreen. They're a whole network of care. Full disclosure, I'm on the board of that organization. I believe in the work that they're doing. There's lots of free programs like Stout Street Foundation. Great program. I worked with them. I was on their board as well. They do a long 18-month course of treatment that's totally free. I'm thinking about Step 13 in Denver, an organization run by, it's called Step Denver. It's run by Paul Scudo. Denver metro area, works with homeless folks trying to get back on their feet that have substance use issues. There are lots of programs out there. The trouble people run into is when I recommend the program, my loved one doesn't want to do it. And that's where we really look at, this, I hate using this word, but you'll know what I mean when I say it, enabling. I don't like the word because it's blamey, but there are behaviors that we as loved ones, family members and friends do that can support continued use. And it's usually well-intended. To not do what we think is loving and caring is so counterintuitive, and that's why it's so important that us friends and family really need to get our own help to be able to best support our loved one, because to do it the way they need it is not intuitive and it doesn't always feel good.
Well, and everyone on this call, many of course aren't lucky enough to be from Colorado and participate in some of those programs that you mentioned. Is there a clearinghouse? Is there a locator? Is there a way people can even know what's available in the early interventions, let's say early psychosis of a loved one? How do we even find out what's available?
Sure. So SAMHSA's website, Substance Abuse Mental Health Association, they have a treatment locator that you can pick and choose and find a bunch of different things about it. One of the things about psychosis is you can access treatment differently, or more rapidly through emergency departments or some of the crisis centers that I had mentioned earlier. Generally speaking, the insurance company and folks like that are really looking at psychosis, and they'll categorize it as an organic illness. Sorry, I'm having trouble here. They'll categorize it as an organic illness, and it can be covered differently. Mental health money and substance use money still are in different buckets in lots of parts of the country.
Okay.
So that's another avenue. That was why, Laura, they might have said to you, hey, say Johnny's using LSD, you might get coverage for that.
Yeah, it was crazy. I remember calling so many residential health centers, and one here in Colorado that advertises quite frequently on the internet said, oh, well, can you get him to lie and say that he's addicted to something else beside marijuana? I asked him if he would, and he's like, are you crazy? No, I'm not going to lie and say I'm addicted to this other substance, so there's still this perception. And I don't know if it's, because here in Colorado, of course, being the first legalized state for recreational, some of our providers just won't cover it, So in that case, if your insurance won't pay for it and you can't find, a free program, do you recommend that parents bite the bullet? I mean, we hear of so many parents spending, hundreds of thousands of dollars sending their child out of state because there's a program available. What's the how do you weigh that as a parent? And even if you do send them out of state with your statistics that, only 30% are going to stay in recovery, how do you ever know exactly what to do?
Great question, Laura. So here's another litmus test for a provider. If whoever's making that recommendation is any good, what they're going to do is have a conversation with you about the long term. So, we could send someone somewhere for 100 grand a month right now. Fine. I want to know what your budget is. What's the 2-year budget? What's the 5-year budget? We need to have this bigger plan. We need to plan this bigger course of treatment. When you pay 30 grand for someone to go somewhere for a month and they leave after 5 days, did you just burn half your money because of the contract you signed? What is the big picture? So that's where this plan A and plan B comes in. Sure, plan A is this great magical program that costs a bunch of money, but what's plan B? What's local? If someone won't go away to this other program, but they'll do partial hospitalization treatment, how are we going to respond to that? That could be perfect. Sometimes people need to be able to prove that they are going to fail to themselves. So I'd rather have someone bomb out of a $5,000 program a couple times than a $30,000 program once and have the budget be blown.
Got it. It's such a difficult issue. What about when the teen is over 18? You mentioned an intervention. Could you explain more about that?
Sure. So there's many of you have maybe seen the TV show, but there's interventionists, folks that you can call. There's some local ones that I can provide the contact info for. And essentially what they do is they come and you call them because you want your loved one to quote unquote go to treatment. But what they'll do is they'll come and actually work with you, work with the family, do a bunch of pre-work and help get you and the family into a spot where you can best intervene. And typically that's like a meeting with the loved one where you've set up treatment and they're ready to go to treatment. The one thing I'll say about interventionists is that interventionists usually bring people to inpatient treatment. So there's a foregone conclusion that you and your mind have made up that your loved one needs inpatient treatment. So I challenge that and say, well, what professional did you talk to help you come to that conclusion? Not that you're wrong, but this costs money. Get another opinion. And if an intervention is indeed warranted, go ahead and do the intervention. These interventionists are experts in getting people to the right places, considering insurance, funding sources, things like that. So they're really good at treatment matching.
And they also, I'm guessing then, can recommend how to match a minor who won't go to treatment, who's under 18, helping you with the right program and finding a consultant and if necessary, ensuring that that youth gets to the treatment safely.
You're absolutely right. They'll escort them to treatment, do all those things. just be wary. There's a lot of unlicensed program in Utah. Utah has regs. Before I knew better, I drove a kid to meet a program in Utah, and they take you out in the woods and you live out there for 9 months. And not that they're all bad, but you need to be wary of those. But they sign powers of attorney and all this other business. There's ways to force kids into treatment. There's legal ways in Colorado to force adults, have a judge force them into treatment. Those are all routes that the interventionist could help you navigate and look at. And sometimes that's helpful and warranted, but a lot of times it's not.
Well, and I think some of the parents perhaps asking those questions are at that place of desperation. So that's a very helpful piece of information. Someone else is saying, I can recommend PAL, Parents of Addicted Loved Ones. It's a national group with live and video meetings. So thank you for that. And one last question, are there places where parents can seek funds if they don't have the funds? Does such a thing exist?
Sure. Counties and churches. So religious organizations oftentimes have that kind of money. If you go to whatever county you live in, go to their Department of Human Services. If they don't have a fund, they might know about one that they can refer you to, for scholarships. Some treatment programs have, payment plans, things like that. I guess helpful. Yep.
And do you have any books you can recommend for parents with young children or young adults in addiction, specifically to marijuana, if you know of any?
Sure. Don't have one off the top of my head.
Okay, that's all right.
Yeah, sorry. If you email me, I might be able to think of some.
And if we have some resources, we will include that in the follow-up email. Everybody will automatically receive with Jay's handouts and some of these resources. And Jay, that hour went so quickly, and we want to thank you so much for the gift of your time, your wisdom, and for helping us all here at Johnny's Ambassadors. And we appreciate it. Thank you, Jay.
Thank you, Laura. Thank you, everyone. Have a great day.
All right. Thanks, everyone. Take care. Bye-bye.